So I'm really delighted to present my colleague as the third speaker of the morning, Dr. Diekema, who's sort of the mastermind behind this whole series, and a pleasure to work with. For those of you who don't know him, Dr. Diekema is Director of Education at our Chairman Katz Center for Pediatric Bioethics, and he's professor in the Division of Bioethics in the Department of Pediatrics at the University of Washington School of Medicine. He's also adjunct professor in the Department of Bioethics and Humanities, Internal Medicine, and the Department of Health Services and the School of Public Health. He's an attending physician in the emergency department at Seattle Children's Hospital. He's been a member of the Seattle Children's Hospital Ethics Committee since 1991, and he's served as an ethics consultant since 1993. He's also been chair of our Institutional Review Board for how many years now? Too many. He's the former chair of the Committee on Bioethics of the American Academy of Pediatrics and is a current member of their Ethics Committee and at the American Board of Pediatrics. Dr. Diekema is co-author of the book Christian Faith, Health, and Medical Practice and author of numerous scholarly publications in medical ethics and pediatric emergency medicine. He's editor of a recent volume, Clinical Ethics in Pediatrics, a case-based textbook published by Cambridge. And today he's going to be talking to us about youth boxing, parental refusals of immunizations, and standing on principle. Please join me in welcoming Doug Diekema.
Thanks, Maureen. So what I wanted to do this morning before we have our panel discussion is look in a slightly different way at the two issues that we've already discussed by talking about two cases that I've interacted with that illustrate both the issue of moral distress and how providers handle that, as well as some of the aspects of conscientious objection. In both of these cases, one of the things that perhaps sets them apart a little bit from the conscientious objection issue is that the sort of philosophical objection to providing a certain kind of care to a patient has sort of moved in the direction of, for lack of a better term, corporatization. In other words, moved to the point where it can be difficult for a certain group of patients to even get coverage or medical care precisely because whole groups of physicians have sort of acted on conscience and refused to provide care of certain kinds or in certain ways. So, and I think the best way to do that is to illustrate that with a couple of stories. So, the first of those involves an experience with youth boxing. And in this particular case, a sports medicine physician at a large hospital and university was approached about covering youth amateur boxing events for the police department who was sponsoring these events. The police department saw sponsoring these boxing events as an important opportunity to reach out to a certain aspect of the community. They made the argument that the kids who came in and used the boxing ring and participated in the events were, in many cases, troubled youth. They were the kinds of kids that were at risk of being involved in gangs or in the drug trade, and that this was a way not only of getting them off the street, but also sort of directing their energies in a way that was more positive than other potential ways that might be directed. So the police had approached, or the organization, which was a police organization, had approached this sports medicine physician about potentially covering these events. In order to do that, the physician had to get permission from the organization because it technically is not covered under the organization's clinics or even malpractice coverage. And in the process of doing that, of course, opened up this can of worms where people started objecting to what they saw as sort of an endorsement of an activity that they weren't convinced pediatricians should be endorsing. So what I want to first claim is that when We make decisions based on principle, and the argument against covering these events was one that argued that it is inconsistent to a certain extent with one's identity as a healthcare provider to provide coverage at an event that puts kids at some risk of injury. My first argument is that when you make arguments based on principle, you have an obligation to make sure that you understand what it is you're objecting to. In other words, that your objection is actually based on good facts. So let's take a closer look at what we're talking about, because we're not talking about Muhammad Ali type boxing when we talk about amateur youth boxing. So it's important to understand what it is we're actually talking about that these kids are participating in. And there are a number of important differences between professional boxing and particularly youth amateur boxing, one of which is that the participants do wear protective headgear. They wear a different kind of glove, a glove that's designed to absorb shocks so that there's less of a blow to the body when they use the gloves. These events cannot take place without a licensed healthcare provider at the ringside. Now, that provider does not have to be a physician. I think it can be a nurse, it can be a paramedic, but it needs to be a licensed healthcare provider of some kind who can render medical assistance should there be a problem. That healthcare provider, and this is also a difference between amateur boxing and professional boxing, has complete authority in these matches to stop the match at any point, and not only that, but restrict any future participation for either a limited time or permanently by any individual who they feel has suffered an injury that puts them at risk. So the healthcare provider is not just being asked to sort of provide coverage when they're asked, but they actually are given authority to stop the match and for a number of reasons, to evaluate the boxer or even to stop the match because they feel someone's at risk. The goal in amateur boxing is not actually to knock out the opponent, and as a matter of fact, that's discouraged. There is a point system. The goal is to score points. Points are not based on how hard a punch is, but rather where the punch has been landed. There are also other sort of protections in place. The minimum age is 11, and the rounds there's only 3 of them, and they're fairly short to sort of minimize exposure to the blows. So fairly significant differences between amateur boxing and professional boxing. Now, those who argued that this is not the sort of activity that pediatricians or healthcare providers should be participating in at any level, which in this case would involve the medical coverage, is that boxing is a brutal sport. It's basically a form of legalized violence. Because of that, it doesn't promote a healthy lifestyle. And it's dangerous to the participants, primarily because of the risk of concussion. And of course, everybody always points to the professional boxers and the sorts of injuries, particularly the chronic injuries they suffer, oftentimes many years after their career has ended. In order to sort of argue against healthcare coverage, you also then have to argue that that by covering these events, you're somehow condoning them. And that's really sort of the thrust of the moral argument against covering them, that this is an activity that should not be condoned, and furthermore, that providing coverage of these events medically does precisely that. It condones the activity, and that's inconsistent with the goals and values of those of us who take care of children. Furthermore, the opponents appeal to the American Academy of Pediatrics policy, which vigorously opposes boxing on the part of any child or adolescent. And what the policy then further goes on to say is that parents should be educated, patients should be educated about the medical risks of boxing by their healthcare provider, and young athletes should be encouraged to participate in alternative sports in which intentional blows to the head are not central to the sport. Then the Academy goes on to say that the Academy itself and those in pediatrics should advocate that boxing organizations ensure that appropriate medical care is provided for children and adolescents who choose to participate in boxing. A fascinating part of the policy, because as it turns out, when this debate goes on, this policy is almost always used exclusively by those who oppose boxing as a reason not to cover medical events. And yet the statement itself says that we have an obligation to assure that these kids get appropriate medical care. So it's not entirely clear that this policy would preclude involvement in medical coverage of these events, and I'm not convinced it actually says that. I think it may say the opposite. So what's the case for coverage of these events? This particular sports medicine physician felt fairly strongly that covering this event was the right thing to do. And among the arguments that she gave were the following, that youth boxing is currently legal. This is sort of the pragmatic argument, and it's going to occur whether we're there or not, which is probably accurate. There's nothing about not showing up as a healthcare provider that's going to keep this event from going on. They will be able to provide somebody to cover. It may not be somebody who's as trained as a sports medicine pediatrician. It might be a paramedic, and it might be somebody who actually doesn't know exactly what they're doing in terms of evaluating somebody for subtle signs of concussion. But they will find medical coverage. The best way to protect these participants, argue those who advocate for coverage, is to cover the events and then put yourself in a position of authority where you can stop that match, you can monitor what's going on with the athletes, you can tell an athlete that they can't box again for another month because they've suffered a mild concussion, or perhaps because it's their second or third that they can't box again in sanctioned events. And furthermore, that participation in coverage is not inconsistent with a political goal of banning the sport. And that's an argument I would agree with, that there's nothing inconsistent about participating in activity like this and still doing what the American Academy of Pediatrics says, which is advocating against this as an activity that's appropriate for youth. Where it gets really interesting, though, is doing some casuistic reasoning, which is to say, if boxing is truly the sort of event that should not be covered medically by those who care for children, then aren't there other youth sports that are equally as risky that we maybe shouldn't be covering, that nobody seems to have any qualms about covering, like football or rugby or some of the other sports that put kids at high risk of concussion? So let's take a look at that latter question. There's not a lot of data on this. The data that's out there suggests that there clearly are other sports that put kids at risk of concussion at a nearly as high risk as boxing. In one particular study, youth hockey showed about half the risk of amateur boxing. Rugby approaches amateur boxing a little more closely. In another study that looks at injuries, the injury rate in high school football appears to be 4.5 times over what amateur boxing is, wrestling 2.5 times over what amateur boxing is, and soccer 2.5 times over what amateur boxing is. In other words, what there's not good evidence for is that somehow amateur youth boxing, and again, what you have to remember is we're not talking about professional boxing here, we're talking about amateur boxing with all of the protections that are in place. There is no credible evidence to suggest that this sport puts kids at more risk than many of the sports that are routinely covered by healthcare providers who don't seem to have any problem with sort of that offending their principles. So when you compare something like football, which is routinely covered by providers, and boxing, the injury rates appear to be fairly similar. The concussion rates appear to be fairly similar. And so the opponents of boxing say, well, but the intent of the sport is different. The whole point of football is to score points, and the whole point of boxing is to hit somebody in the head. Well, first of all, as I just showed you, actually, if you look at the rules of amateur boxing, the intent of that sport is to score points, and you don't have to hit somebody in the head to score points in amateur boxing. Likewise, anybody who has even a sort of general familiarity with football knows very well that if you're a lineman, your goal actually isn't to score points. Your goal is to knock the heck out of the guy who's across from you on the line. And so it's not entirely clear that there are any sort of real differences between these sports in terms of their intent that make any sort of sound philosophical sense. And as far as benefit to youth goes, many people argue that football is appropriate to allow young kids and adolescents to have exposure to, even though it carries a risk of injury because of the benefits they derive from participating in that particular sport. But what the Police Association was telling the sports medicine physician is that exactly the same argument applied to youth boxing, that these were largely at-risk children and adolescents, that this was an activity that in many cases was redirecting their energies to although maybe not the healthiest direction, certainly a healthier direction than they might otherwise be pulled, and that it was providing them with some sense of well-being and some sense of accomplishment, and also providing them with exposure to adults that could be a positive influence. Many of the same arguments that are used to justify relatively dangerous sports like football and rugby and soccer and other sports that run a risk of concussion. So that's case number one, and I'll sort of get back to the whole sort of argument about standing on principle in a minute. The second case I want to cover is that of parents who refuse vaccination. And in particular here, I'm going to give you a little background about this issue just so you understand it. But in particular here, the issue I want to focus on is what's becoming an increasingly common practice, which again is grounded in the sense that my identity as a healthcare provider who takes care of children demands this. In other words, that I'm standing on principle here. And that is the practice of refusing to see families who have decided not to immunize their kids. And not only is that becoming an increasingly common practice, but many of these individuals and many pediatricians are becoming much more vocal about not only the fact that that's justified, but also that it should become much more commonplace. To the point where I have now been hearing from individuals who live in communities where they would have to travel 100 miles, for example, to find a pediatrician if they chose not to immunize their kids, precisely because the pediatricians and family docs have basically banded together and all sort of decided to act on principle, so sort of made this corporate decision. In the same way an organization might make a corporate decision that we're not going to allow any of our sports medicine docs to participate in covering amateur boxing events. So just sort of a brief overview of why this issue is so important to pediatricians. Historically, we've never had a situation where everybody wants to or is willing to immunize their kids. This has always been a problem. And it presents a problem, certainly from a public health perspective, because most of the vaccines that involve communicable diseases require that a certain level of the population be immunized before you actually achieve what's known as herd immunity, where spread of disease becomes very unlikely. If you can achieve herd immunity willingly, then you're in a situation either where you're going to have disease outbreaks and you're going to have to tolerate those, or you're going to have to coerce your population in some way to get vaccinated. Now, we know that we have a problem with parents being hesitant to immunize their kids. In 2000, 19% of parents didn't think vaccines had been proven to be safe. Now, some of those people are immunizing their kids, many of them on alternate schedules, but some of them are not immunizing their kids at all. And most pediatricians, and presumably most family docs and most nurse practitioners and public health nurses, report that they do have families that refuse to vaccinate their kids. And we also know that about 20% of parents now at least defer or refuse some vaccines. If you look at this sort of at a public health level, what you find is that at least in terms of how many people are asking for exemptions from the requirements for school entry to allow their kids to attend school despite the fact that they're not vaccinated, there's a lot of variation across the country. Washington State does tend to stand out a little bit in terms of the number of exemptions that are sought and granted. But the other thing you find is that when you look more locally, it becomes even more impressive. In Washington State, for example, and what you want to focus on here are the red counties. it's clear that there's regional variations here. And I don't have the numbers on these slides, but what I can tell you is that if you look at a place like Yakima County, for example, the exemption rate is about 1%. There was at least a recent year where I think it was Ferry County had an exemption rate of 30%. So there's huge variation from county to county depending on the sorts of people that live there. But what I want you to notice here as I just flip through these next few slides is how things have changed over time. And again, focus on the red because that's an exemption rate of greater than 5%. So this is 2004, this is 2005, 6, and this is 2006, 7. So what you see here is a trending toward more people seeking exemptions. This is why professionals who take care of children and try to protect them against health threats are concerned about this issue. So that's another way of saying that I understand the moral distress that pediatricians and public health nurses and family docs experience when they're faced with families who don't want to immunize their kids. So this slide I've borrowed from Doug Opel, who has done a nice job of sort of providing an understanding of who these families are. And the point of this slide is that this first column, most people actually do accept vaccines. So that's sort of the positive spin on this. 70% of the population really doesn't have a major issue with vaccines. They may have some questions. They may have read about some of the concerns, but in their minds, it's the right thing to do. And they're going to basically follow the recommendations. You've got a second group that is much smaller, and that's the truly anti-vaccine crowd. And I think one of the powerful things about this slide is hopefully that it dispels a myth, which is that if you're not willing to vaccinate your child, you're in this camp. The anti-vaccine crowd is a group that it probably is the one that frustrates healthcare providers the most because it really doesn't matter what you say to this group. They have already decided, often for philosophical reasons, but perhaps for other reasons based on their beliefs about vaccines and what they do to the body and so on, that they will not vaccinate their child, and there's nothing a provider can say to change that. But this represents a tiny percentage of the population. This is probably less than 1% of the population. This is a group that we could quite easily tolerate and still sustain herd immunity for every communicable disease. So the group that really poses the problem is the group that Doug calls vaccine hesitant. And this is the group that it's not so much that they have major philosophical objections or intractable beliefs, but that they're concerned. They're worried about the vaccine. They want to take steps to minimize risks they've perhaps heard about. They're not sure who to believe, although most of this group does trust their provider. And they often have an interest in getting information from their provider. But what perhaps makes them different from that first group, the acceptor group, is that they're also getting information from other sources. And so the provider's information sort of has to fit into everything else they're hearing, and it's sort of that person may decide that the information they're most worried about is what they're hearing from other sources and choose either to delay vaccination or not vaccinate at all. This is not a uniform group of people. This is a group of people that really requires a healthcare provider to look at their individual needs, because some of them are worried about autism, and some of them are worried that the ingredients in vaccines are unsafe, and some just don't want their child to get 5 injections at a visit. And it's different for every one of these families, and so it's very difficult to actually pigeonhole them into an easy group. There are a lot of contributors to this hesitancy. Many of the parents who are reluctant to vaccinate their kids, at least reluctant to vaccinate them on time, have belief systems that perhaps don't fit into sort of the scientific hypothesis-driven medicine that we try to practice. They've heard things about the effect of vaccines on the immune system. They've heard that vaccines don't work. They've heard that vaccines cause disease. Lots and lots of different things that may not necessarily be founded in science, but which nonetheless they're hearing from what at least they consider to be a credible source. We've also lost memory of infectious diseases. Most people don't know what polio is. Most people don't know anymore even what Haemophilus influenza B is. And so it's difficult to emphasize to a parent how important it is not to contract this disease because they've never had experience with the disease, and to them it's a distant problem. We know that the population in general has a general compromise in their ability to assess risk. That's true of most of us. There have been lots of books and papers written about this, the irrationality of decision-making even in very intelligent people in terms of what we avoid at all costs and what we do every day and how the risks of those things stack up. Many of the things that people are very anxious about doing are actually less risky than what they do every day in terms of getting in their cars and driving on the road and so on. And so risk assessment is a bit of a problem in terms of getting people to do that, perhaps in a scientific way. And then the whole business about who actually serves as an expert is also a problem. It may be clear to many of us in this room that Jenny McCarthy is not an expert on vaccines. She has one child who she has attributed some of his problems to vaccines, but she really is not an expert on vaccines. She doesn't have a background to allow her to be that. And she shouldn't be perceived as a vaccine expert. But that does not change the fact that that may not be clear to our patients. They may not have the ability to see that she's not an expert or why she's not an expert. Why shouldn't they take what she says just as seriously as what I may be telling them? So there are lots of contributors to this. And among other things, it's important for physicians to recognize that these contributors exist and that parents have lots of concerns and that they're diverse concerns. So what should a pediatrician, a family doc, a nurse practitioner's approach be to parents who refuse vaccinations? And there's several options here. One is you respectfully continue to work with the family, and it's probably no secret that that's sort of the option I'm moving toward advocating. But another option that's increasingly being chosen is this one I've mentioned, that physicians and others are now asking families to leave the practice when they persist in their refusal to vaccinate. And in some cases, there are practices now that are screening new families on the phone before they've even joined a practice about their willingness to vaccinate. And if the answer is no, they won't even make an attempt to allow them into the practice to see whether persuasive techniques work. In other words, there's a screening that occurs before they're even accepted into the practice. And that sort of seems to be an increasing trend. So the principle here that is being relied upon by those increasing numbers of physicians in particular who are advocating this approach is that vaccination is central to child welfare, and to fail to do so is inconsistent with the role of the pediatrician. And so, again, it's very much like the youth boxing argument. It's really an identity-based argument. It's to say, I am a professional who has vowed to optimize child health. And doing so, the biggest, perhaps the greatest tool I have at my disposal to do that is vaccination. And if I have families that will not accept what I consider to be the most important tool in my armamentarium for protecting children, then I can't provide care to that particular family. And that's really the principle that's being relied on. There is a secondary principle that I think has been increasingly relied on, which I think, quite frankly, my somewhat cynical view is that this is being touted more and more because people understand the weakness of the principle-based argument. And that is that unvaccinated children represent a threat to the other patients who happen to be sitting in the patient's waiting room. I would just simply point out that if you are willing to see sick children in your waiting room, then those sick children also represent a danger to the kids in your waiting room. So what are the arguments against firing? What are my arguments against firing? First of all, it's unlikely to accomplish the goal of getting the child vaccinated. I mean, telling a family you won't see them because they won't vaccinate their child will not get that child vaccinated. Most families aren't going to say, oh, okay, then I'll do it. Most families are going to be a little annoyed with you and ticked off and probably less likely to listen to what you have to say after you've put your foot down like that. this is very much like the boxing example. I mean, simply saying, I won't cover this boxing event because I think boxing is dangerous is not going to change the fact that these kids are going to participate in amateur boxing events. It may further harm the child, just like not having good medical coverage at a boxing event may harm the boxer, because there's now not somebody there who really can recognize the subtle signs of concussion. What you've effectively done in telling a family that you will not provide them with medical care because they won't vaccinate their child is denied that child your ability to take care of them for their other needs. And particularly if you're in a small rural community where there's only one or two providers, none of whom accept families who refuse vaccination, you may have severely limited that child's opportunity to get care that they need. Which I find particularly vexing in the case of children, because it's not the child who made this decision about vaccination, it's the parent. And yet the child is the one that ends up without perhaps the best medical care. I think it also ultimately undermines trust in medical professionals. These families, it certainly doesn't enhance trust when you tell a family you won't see them in your practice because they won't do what you want them to do. And so it does undermine trust in some important ways. Furthermore, continued dialogue, the willingness to continue to see these families, shows them some degree of respect, maintains an open communication channel, and gives you the opportunity in the future to make an impact on that decision that they've made at this point in time, but which they may change their mind about. And again, if you remember the slide I showed that I borrowed from Doug Opel, remember that the huge majority of these families are families that are somewhat conflicted about vaccination. In other words, there usually is some opening there for you perhaps to make inroads in the future with them if you keep that opportunity open by not asking them to leave your practice. And then I already alluded to the fact that it's not clear to me that just keeping kids who are unvaccinated out of your waiting room really protects the other patients in your waiting room. The fact is that most healthcare providers are seeing sick kids as well as well kids, and there are better ways of protecting the well kids from the sick kids than just not seeing kids who are unvaccinated, because 95% of what we see are not vaccine-preventable illnesses. They're things that are viral and not protected by vaccines. And so if you really take this argument seriously, you probably need to segregate your waiting room so that the babies who are unvaccinated and are there for their well child checks are not being exposed to anybody who may have contracted a disease and be there for sick care. So let's go back to this tension. And I want to make it clear that I understand where people are coming from when they say, I don't feel comfortable covering amateur boxing events and I don't feel comfortable seeing families who won't vaccinate their kids. And I'm not arguing that every healthcare provider should be willing to cover amateur boxing events, but where it particularly becomes a problem is where that decision becomes sort of corporate. In other words, where an organization says, none of you can do this. And where pediatricians band together and say, none of us are going to see families who vaccinate their kids. This is really a long-standing, these two arguments are really a long-standing debate in philosophy about whether deontological theory or consequentialist theory should take priority. Deontological theory is really principles-based theory. You act on principle. I never lie. I have a principle that I don't tell lies, and I never lie. I have a principle that says I, won't cover health care or sporting events that cause potential damage to patients, and I'm going to act on that principle, and that's the rule. The problem with any purely deontological approach is that there will be people who suffer because you're standing on principle. In other words, if you're unwilling to cover those boxing events, you may feel good about the fact that you're standing on the principle that is part of your identity. But the problem is that now you've got some amateur boxers who may not have adequate medical coverage because of your unwillingness to be there. You now have some families who may not be able to get good medical care for anything precisely because you won't see them because of a decision they've made. Furthermore, principles can conflict. In other words, it may be that you're acting on principle when you refuse to cover an amateur boxing event or refuse to see families that won't vaccinate. But the fact of the matter is there are other principles that should be governing your life as a healthcare provider and should be part of your identity, one of which is to seek the welfare of every individual patient that that can potentially be part of my practice. And that includes, it seems to me, children whose families have refused to vaccinate them, and adolescents who have chosen to participate in amateur boxing. In other words, that's not our decision whether that youth participates in amateur boxing, and it's not our decision whether a parent vaccinates their child. Our decision is whether we're going to take care of those kids for their health care needs when they have those needs, despite a decision that we may not agree with. And I don't think there's anything inconsistent about that. I think we should worry about principles that don't serve the needs of our patients. And at a minimum, I think we have an obligation to explore further whether we should really be acting on principle when the outcome of that is that at least some of our patients may suffer harm because of our decision to act on patients. My argument is that our first duty should be the welfare of our individual patients, the individual child, and not standing on principle because of a decision that's been made either by that adolescent or by their parents. Ultimately, what I'm saying is the governing principle here, I think, should be beneficence, that we should seek to do good for our patients, and that obligation includes our avoiding unnecessary harms on the patient and trying to prevent harm to the patient, which I think you can best do by counseling families, which requires keeping them in your practice, and also which I think might involve covering amateur boxing events where you now have the authority to stop a match because you think somebody has taken too many blows to the head or their behavior suggests they may have a minor concussion. So in conclusion, I don't have a problem with people who act on principle, but I do think sometimes those principles aren't adequately enough explored. And I think when you find yourself in a situation where acting on principle may actually cause some of those other individuals to suffer harm because you're acting on principle, you have an obligation to very carefully explore whether you really, in fact, should be acting on principle. Thank you.